emergency patient and who is all smiles. And I can't see Meenakshi's face, but Dr. Parveen Bhatia should know this, that I mentioned one of his aphorism in the morning. If there is any doubt, there is no doubt.
Sarfraz, you need to start my video. It has been stopped by the host.
Sushil, can you please show us Meenakshi's video, please? Yes. So, Sumeet, are you able to open up your screen now?
No, not so far.
Okay.
Okay.
You just have to open up your screen, yeah.
Yeah, meantime, I can always thank Sarfraz for including us, one. Second, excellent job being done. I think this is one of the best virtual conference you have organized, and very well done, all timed, very well timed. All
Thank
good.
you.
Oh.
Thank you. I think this is an amazing experience. Dr. Amitabh Goel, I can see you now. Dr. Amitabh Goel, sir, kaise hain aap? All right, I think is Sumeet, any problem at your end?
Yeah, I have some very impressive names with me today to be part of this hernia panel. We have Dr. Parveen Bhatia. Dr. Parveen Bhatia is a veteran laparoscopic and minimally invasive surgeon in India, and he is very well known across the country and globally. Dr. Parveen Bhatia is also the medical director of Global Hospital in Delhi, and also a senior consultant at the Institute of Minimal Access and Bariatric Surgery at Sir Gangaram Hospital. We welcome our friend Dr. Macky from Faylona from Philippines, who is an associate professor of surgery in the University of Philippines in Manila, and he's an Indophile. We have had him here many times in India, and it's really a pleasure to have Macky here. We also have Dr. Meenakshi Sharma, my good friend, and she's from Paras Hospital. She's a senior consultant in hernia, laparoscopic, and bariatric surgery at Paras Hospital. And of course, our veteran IAGES executive member and a senior member, Dr. Amitabh Goel, a senior surgeon from Indore. So after this brief introduction for all of my panelists, the job given to us today is to look at some case capsules for hernia and to see how we can decide on what is the best management for these patients. Well, you know, these hernias comes in different shapes and sizes, and to lump them all into a single entity called as ventral hernia is actually trying to simplify a complex set of different kind of problems, as you will see in these images, and they all can be clumped together as ventral hernias, but they all have very different managements, and it is difficult to do justice for all varieties of these hernias in this 45-minute discussion, but we will stick to the time what has been given to us. Friends, with this brief introduction, I will just say that there are many choices. I mean, today the hernia surgeon is spoiled for choices because there are many options to do, which include open repairs, endoscopic repairs, intraperitoneal mesh placements, extraperitoneal mesh placements, different techniques to do this, component separations. All this has made the algorithm actually on what surgery to use where very complicated, and I hope my panelists today are going to help you simplify some of this complex algorithm mechanism for management of hernias. So we go to the first clinical scenario or the first case capsule. Now, this is a small hernia, which is a 2 centimeter or maybe even less than 2 centimeter primary hernia. You can see that this patient is not obese. There is no significant comorbidities. So my first question goes to our senior panelist, Dr. Parveen Bhatia. Dr. Bhatia sir, do you think that this patient requires only a primary repair or a mesh repair? Because this is often said that, we can still do the primary repair in a small umbilical, paraumbilical hernia. So what is your opinion on this?
My opinion is mesh is a must. Laparoscopically, we should place the mesh if you are trained to do laparoscopy. And even if you are an open surgeon, then also mesh is a must. You cannot have the low recurrence by just suturing the defect and expecting the best result. Mesh is a must.
So any of our panelists has a different opinion that that we can get away with doing only a suture repair in a 2 centimeter or less than 2 centimeter small hernia, Macky?
No, I agree with Professor Parveen that a mesh is required in this case.
Dr. Meenakshi, Dr. Amitabh, everybody agrees that we require a mesh with irrespective of the size of the defect.
Yes, definitely. I do agree.
Sumit, I fully agree with Parveen what he said, but if the patient is quite obese and still hernia is not 2 centimeter, I prefer to suture from outside some people to put one figure of it and like the if patient is obese, MI is more than 35.
Sorry, your voice was breaking a little, Dr. Goel, so I couldn't really clearly understand what you said. But I can make out that I think you agree with all of them that the mesh is an important part of any hernia repair, irrespective of the size of the defect. Am I correct, or is there anybody disagreeing with this view?
Yeah.
So there has been a recent study in the British Journal of Surgery which said that any defect less than 2 centimeter also needs to be reinforced by mesh. However, if it's a very small defect size of less than 1 centimeter, we may consider repair without a mesh. If it is a thin patient, lean patient, then we may consider. But a defect size of 2 centimeters, definitely less than 2 centimeter, definitely needs a mesh, and definitely a laparoscopic approach is better.
Okay, so
Dr. Sumeet, I may just add that if, for example, previous laparoscopic cholecystectomy has been done, and if it was a 10 mm incision, and if it has caused a recurrence or incisional hernia, then also mesh is a must. This is very, very important, that even if it is 5 mm, even if it is 10 mm, it has to be done by laparoscopic mesh placement.
okay, so I think this is a very important message that all our senior panelists are giving to the entire audience, that mesh is a must, and we have come beyond the era where we can consider saying that suture repair is giving us equally good results. Now, second question is open versus laparoscopic repair. Again, this discussion I've seen in a lot of the forum, and that they give a small subumbilical incision and make a quick pre-peritoneal plane by blunt dissection and place a mesh in the pre-peritoneal plane and do an open repair. So, Dr. Faylona, do you prefer to do open repairs in small parambilicals or small umbilical hernias?
It actually, what's the BMI of this patient?
The BMI is normal. That is why I said this patient is not complicated.
I see. It actually, normally what I do in my practice is that I present both sides of the coin, whether to do it laparoscopic or do it open. And of course, both will have its advantages and disadvantages. And I let the patient decide for such a small hernia what he or she prefers to have done. One thing that I failed to say earlier is that you have to also consider whether this patient had diastasis or not, because umbilical hernia plus diastasis, that has to
We
be.
will come to that. We will come to that. We will come to that.
Yeah.
That's
No,
a
but,
different case scenario. I will present that.
yeah, but what I'm saying, Smith, is that like, if there's a concomitant diastasis with this hernia, then I would probably prefer doing it laparoscopic than an open surgery. So
Okay.
it's a tough point.
So, Dr. Amitabh,
Am I audible? Yes.
yeah, Dr. Amitabh, can you hear?
That intraplateral incision,
Yeah, Dr.
open surgery, if patient is cannot able to
doing open and lap repair in this situation. Dr. Goel, can you hear me?
yes, and your voice was break. Ask me something.
Yeah, I was saying that what would be your approach? Can you just tell us about the plus and minus of doing the open or a lap repair?
Yes, if patient is really poor, cannot able to afford the composite mesh and tackles, then definitely intra-umbilical small incision pre-peritoneal can be applied. This option is there, but I prefer approach.
We are losing Dr. Goel's voice. My other panelists, can you hear him?
Yeah, I just want to say that Dr. Goel wants to say that if the patient is not able to afford the composite mesh and the cost of the tacker, then he would definitely offer the open surgery. But honestly, my feeling is that if the patient wants the open surgery only, then I will say get it done from somewhere else. And once the recurrence is there, I will do the laparoscopic way.
Oh, well. That is that.
I do open surgery very well.
Well, I like the certainty with which and the confidence with which we choose our option. But actually, if you go to literature, it's very difficult to find a clear-cut sort of benefit of lap repair over open repair in these cases. Dr. Meenakshi, what remains your approach for these patients?
Dr. Sumeet, in such patients with a defect size of even less than 2 centimeters, it has been at least 3 times that I have come across multiple small defects near the original defect which has been detected clinically. So I definitely believe in going laparoscopically and counseling the patient accordingly that, we are going in for this size of defect. And also because in one of my patients in whom I had done an open repair long time back, she came up with a recurrence 1 centimeter below the hernia, which was repaired initially. So I believe in going in laparoscopically, looking at all the defects, looking at the size of defect, looking at the contents of the defect, then taking a decision as to how what kind of mesh do I need to put it, and that is how I repair it.
So I think that is good. I think at least there is a sort of consensus amongst our panelists that that mesh repair is a must. Number 2, that that they would prefer a laparoscopic or minimally invasive approach unless there is issues with the affordability for the patient. Now, third question, Dr. Bhatia, to you. Bridging
Sumeet, just a sec. Dr. Shenoy has also joined. You may not be able to see him on your screen, but Ganesh Shenoy is also there with us.
Okay. So just give me a minute to welcome Dr. Shenoy. Dr. Ganesh Shenoy is from Bengaluru, and he is a very, very reputed consultant, minimal access GI and bariatric surgeon. He works at AV Hospital and Fortis Hospital in Bangalore and has been the faculty and chief coordinator for laparoscopic surgery training at the Best Institute. He is an EC member from the South Zone for Hernia Society of India. And Dr. Shenoy, welcome to. So we were discussing simple cases.
Yeah, I was observing Dr. Sumeet.
Yeah. Nice to have you. I hope everything went well for your case. And so we were starting with the smallest hernia because the smallest of the hernias sometimes create the biggest of the controversies. And there is controversy regarding primary versus mesh repair, open versus laparoscopic repair. And fortunately for me, all our panelists agreed that they would go with a mesh repair and a laparoscopic repair.
Yeah.
Dr. Ganesh, do you agree or do you have something else to add here?
No, not definitely. Like I would prefer, according to the recent RCTs, all RCTs point towards a laparoscopic repair with the use of the mesh. Because the recurrence rate, there are some controversies regarding the primary suture repair of such hernia. But definitely we know that 5 years down the line, the hernia is going to recur. The recurrence is at least 35 to 45 times more with the primary suture repair. So I would like to go ahead with the mesh repair, like to go ahead with the laparoscopic. I agree with all other panelists.
So good. I think we have solved these 2 issues conclusively in this panel discussion. Now we go to the third point. Dr. Bhatia, we all started when we started doing intraperitoneal onlay mesh repairs, we were not routinely closing facial defects. So now we routinely close them. But for a small hernia, what do you think? Is it okay to do a bridging repair or you need to close the facial defect?
No, we have realized that if we close the defect, the chances of seroma formation is definitely decreased. Initially, all of us were not closing the defects and we were facing the seroma, and we used to tell the patient that it will take 3 weeks, and then after 3 weeks, 6 weeks, 6 weeks, after that 12 weeks, and so on and so forth. So according to us, IPOM plus is the answer.
So Dr. Bhatia says IPOM plus. Everybody agrees with the choice of IPOM plus, or somebody wants to say that they will want to place an extraperitoneal mesh in this situation. Dr. Meenakshi, intraperitoneal or an extraperitoneal mesh?
No, I would go in for an intraperitoneal mesh, just like Dr. Bhatia. And another important reason why I would like to close this defect is because, you know, when I pull in the sac and I suture it, it's going to give much better cosmesis, especially for the female patients, and why not even for the male patients. So I do believe in closing it and, you know, kind of inverting the sac.
Right. So, Dr. Goel, intraperitoneal mesh or an extraperitoneal mesh in this situation for you?
IPOM plus. Switching.
So, an intraperitoneal mesh.
Yeah, he says IPOM plus.
Yeah. But the connectivity is not so good. So, yeah, Dr. Macky, would you consider doing PAPP repair in these situations?
Probably not. It would be simpler to just do a IPOM plus in such a case.
Okay. So we have seen that Ganesh, is it same for you, IPOM plus and using a composite mesh?
No, I'm for IPOM plus and using a composite mesh. Since the defect size is small, it's less than 2 centimeter, and if there is association of rectus diastasis in a female patient post pregnancy, then I would like to give an option of scola also in this patient, because it's a safe alternative.
Yeah, we will come to the diastasis, yes. Yes, so I think, you know, it's nice that, you know, this is a good message going from all the panelists that, you know, mesh repair, lap repair, closure of facial defect, and all of them would do IPOM plus. So this is a good message, but there is also the option of doing a trans-abdominal pre-peritoneal repair, which is also becoming popular these days for these small kind of primary defects. But, you know, we want to show how things can change with the different wound factors or patient factors. Now, you know, this is what Dr. Macky was speaking of, that this is a female patient who has got again a small, less than 2 centimeter umbilical defect, but has an associated divarication of recti. So now we go on to the discussion, Dr. Macky. You were saying that you do this by a laparoscopic approach, and what would you do to the diastasis?
Dr. Macky is asking you that if the divarication is there and umbilical hernia is there, so what is your choice?
Yes, what is your approach when you will attempt this?
Are you asking me, Sumeet?
Yes, I'm asking you, Dr. Faylona.
I see. So if there's a divarication, and then that divarication has to be plicated. As to the approach, there are so many ways of approaching it. You can do scola, you can do milos, you can do intraperitoneal still and do the plication from inside. And of course, the issue is whether you would put mesh to also cover the divarication. More often than not, I would do that. After the plication, I cover the part of the diastasis with the mesh as well. So many ways of approaching it, whether extraperitoneal or intraperitoneal.
So, Dr. Bhatia, do you think that all diastasis require repair, or is it okay just to do the hernia and leave the diastasis alone?
Very nice question.
With the diastasis.
Very nice question. The answer is that we should always discuss with the patient in the preoperative period. And preoperative counseling is far more important than the post-operative discussions. And in this, if the patient is having symptomology, if the patient is bothered about the divarication, and she is going in for ventral hernia repair, definitely I would love to sell that yes, the muscle function can be restored better if we do the extraperitoneal or E-TAP method of repair, and both the recti can be closed. So it should be discussed beforehand rather than explaining it afterwards.
So we come to the next clinical situation, Dr. Meenakshi. This is again, as I said, that how the management can change. Now, this is a patient who may have a, on the right upper picture, a strangulated bowel with discoloration of the skin, and you can see that it's a possible strangulation of bowel inside the hernial sac. Now, when you come across this situation, how does your management for the hernia change?
So immediately, Dr. Sumeet, this is the time to go in for the open approach. When you suspect strangulation, there is no other way. You really have to open and see.
And would you still use a mesh, supposing if the bowel is resected or not resected? How would your approach change regarding the usage of the prosthesis?
Well, in this situation, we can see that there will be infected fluid in the hernial sac, and this is not a good setting for putting in an implant or a mesh for that matter. So in this patient, I will avoid putting in the mesh, do a sutured repair, a proper sutured repair, counsel the patient accordingly, and then proceed.
Okay, Dr. Ganesh, the left bottom picture. Now, again, same supraumbilical or paraumbilical or umbilical hernia, but now this is a patient of chronic liver disease with ascites, and very common to have these patients with umbilical, paraumbilical defects and hernias. Yeah. So how do you manage this patient now?
Yeah, there are two schools of thoughts. One is an elective repair, and another is if the patient is waiting for a transplant surgery. So in cases nowadays, we advocate an elective repair of umbilical hernia in a patient with ascites, provided he receives appropriate medical management of the ascites before we go in.
Right. And what are the potential pitfalls of repairing this kind of hernia?
Pardon?
I mean, would you repair this hernia with a mesh, without a mesh? What kind of sort of pitfalls can you expect when you operate on CLD ascites patients?
Yeah, one is a decompensation. A patient can go into a hepatic encephalopathy. Patient can develop a hepatorenal syndrome. So the consequences need to be explained to the patient. Then definitely I would like to use a mesh, because the recurrence rate in a patient with umbilical hernia and ascites will be higher if you do a primary suture repair because of the increased intraabdominal pressure. And this intraabdominal pressure builds up rapidly in a patient with ascites. So the recurrence chances are high. The recurrence chances are higher compared to the risk of mesh infection. And compared to the recurrence chances are higher. So I would like to put a mesh in this patient, and the approach, let it be an open approach or a laparoscopic approach. After discussion with the patient, I would like to go ahead with the laparoscopic approach in this patient.
Right. So again, last, Dr. Amitabh, this is the right bottom picture again of a similar sort of, umbilical, paraumbilical hernia, but you can see that he has got a lot of skin stretching and big sac, and so what are you going to do here? I mean, if you do a laparoscopic repair, whether it is IPOM or IPOM plus, how are you going to give him a cosmetically good result?
Dr. Amitabh?
Definitely, I would like to go for laparoscopy and reduce the yes. Can you hear me?
Yeah, your voice is very low.
Can you hear me?
Yes, go ahead.
Hello?
Yeah, go ahead, Amitabh.
Can you hear me?
Yes, go ahead.
Yeah, I would like to go for, laparoscopy, and if there is some content, we reduce it. Like to put the mesh inside from inside, and I would like to go for IPOM plus. What the skin holes will be there will automatically subside later as time will go.
So you don't need to remove this extra skin on the surface? To give a better
not necessary. Not necessary. Yeah. They put the compression from outside for 21 days, it will go down. But if she's a female, later on we can go for some plastic surgery type thing. Otherwise, not required.
Dr. Bhatia, do you?
Yeah, Sumit, I would say that in these kind of situations, we have never ever removed the skin, redundant, this kind of skin, because if, as Dr. Amitabh was also mentioning, that if you put in a piece of 10 pieces of gauze over it and put a micro pore, and then usually normally it sets in, and after a few weeks you are not able to see the much of redundancy. But if such kind of skin is there, we should always explain to the patient that I'm not going to expose my mesh to the external environment at this stage. Skin is the best cover. Later on, if you think that yes, you need better cosmesis, then you can go in for plastic surgery or removal of the skin. One. Second small bit which I wanted to add to Meenakshi's thoughts were, in case of umbilical hernia, which you have shown, it is query strangulated, query obstructed. We have a low threshold of doing a diagnostic laparoscopy and then decide about the size and site of the incision also. Low threshold of doing a diagnostic laparoscopy. Many times it appears from outside that it is a strangulation, but inside you find only incarceration, only obstruction is there.
Right. Thank you. So basically, my idea was of putting up this slide was that you can have a similar sort of umbilical hernia, same 2 centimeter defect size, but the management is going to completely change depending upon the hernia factor, or there could be a wound factor like a very hypertrophic skin or ulcerated skin, or it could be patient factor like chronic liver disease, ascites. So there could be many factors, and in a similar sort of hernia, the management will completely change. So that was the idea. And then we go on to the next clinical scenario. Now we come on to this incisional hernia. Now the first case scenario was a primary, but now this is an incisional hernia with a defect size of about 3 to 7 centimeters. This could be around 5-7 centimeters. Dr. Faylona, is there anything different in your workup of this patient compared to, say, when you approach a patient of a primary hernia?
I didn't hear. I didn't get to Sumeet. Can you repeat it?
I'm saying, is there any difference? Sort of investigate this patient with an incisional hernia compared to a patient of primary hernia.
Yes, because normally for an incisional hernia, you have to have more investigation as to what type of surgery was done before, and what type of closure was done before. So I'll probably do more imaging with incisional hernia cases than primary ventral. But in both types of cases, imaging would definitely help once your size of the defect gets bigger and bigger. So you have an idea where your musculature is, you have an idea whether your muscles have thinned out, and all those things. So many things can be gained when you do imaging in such cases.
Right. So I think the important point, the message here is that once you have an incisional hernia, imaging becomes very important to know the landmarks and to know the intra-abdominal situation, and so CT scan becomes mandatory for that. So of course, now at this point of time in this type of hernia, there is no question of a non-mesh repair. So there are still some papers which are trying to say that there is some kind of non-mesh or suture repairs. Anybody, I don't think any of our panelists will agree that there is any scope of non-mesh repair here. Is there any scope of non-mesh repair?
No.
Anybody wants a non-mesh repair in this situation? I'm asking this question because there are many fears in different parts of the world now associated with mesh, and therefore some people are bringing out techniques again for the non-mesh repairs.
Mesh is a must.
Mesh is a must. Okay, so we go on. And I think all of us also agree that once the defect size is this big, around 5 to 7 centimeters, the closure of the facial defect is a must. So anybody disagrees with the fact that we can get away without closing the facial defect in such situations? So I think again there is agreement with everybody. So Dr. Ganesh, what would you do in these situations? This is a situation, I've shown you the pictures, this is a 5 to 7 centimeter defect. in a previous midline upper or lower abdominal incisional hernia, what is going to be your approach to repair these cases?
The first is I would like to go ahead with an laparoscopic mesh repair.
Okay, so now, yeah, so now we know that, okay, now laparoscopic or endoscopic repair is also now that, you know, there are many different techniques. There is a E-tap technique, there is a Minos technique, and there are other techniques for extraperitoneal mesh placement. So do you choose to do any of these procedures, or would you go still with IPOM plus?
Yeah, I would like to go ahead with an IPOM plus repair in such cases.
Dr. Bhatia, you have some, you know, more experience of using the E-type approaches to these incisional hernias, and even in complex situations like parastomal hernias. What is your choice? You have been doing IPOM plus for many, many years now, and now what is your choice? Because you do all these surgeries.
I would still say old is gold.
Okay.
We
So
will carry on.
IPOM
For the defect size of 3 centimeter to 7 centimeter, the first choice would be IPOM plus. If it is more than 7 centimeters, definitely that will be a subset in which we will have different procedures which are available. I know that you are going to ask later on. But above up to 7 centimeters, IPOM plus, close the defect and place in a larger size mesh. And it should be, one should always be cautious about mesh defect ratio. And then
So I was going to ask Dr. Meenakshi about that. Dr. Meenakshi, you know, one of the issues that, you know, typically that comes with IPOM placement of mesh is the size and the type of mesh and how to fix it. So, you know, what is your choice when you go for the intraperitoneal mesh on choosing the size, type, and fixation technique?
So type is of course a composite mesh. Size. So before closure of the defect, I carefully measure the size of the defect. It can be measured by, you know, taking in a scale inside the peritoneum, but my way is I would like to map it out with a needle and put in that needle, mark it on the skin, then deflate the abdomen, and then measure the size of the defect. So when you measure the size of the defect and afterwards you close it, still I think depending on the BMI, I would like to have an all-round margin of 6 centimeters, maybe more if, you know, the BMI is more, and if it is sometimes there is a recurrent incisional hernia also. So definitely 6 centimeter margin is a must.
Right. Regarding mesh fixation, you know, Dr. Goel, there are absorbable tags, non-absorbable tags, intraperitoneal suturing. What is your favorite technique and what is your experience regarding the mesh fixation in IPOM?
What I prefer first of all, a 4-quadrant suture is must in all cases. In the mat. Number one. Number two, I always use non-absorbable tags. I do some absorbable tags, but I don't feel comfortable in absorbable fixator. So I use non-absorbable tags with 4-quadrant sutures.
Okay. Okay. So anybody has anything to say, Dr. Ganesh? Do you have anything to say of, you know, usage of absorbable versus non-absorbable tags?
No, I would like to go ahead with an absorbable tag.
Okay.
So suppose
That
if
is a
the
different
not
opinion.
affordable, say anyway we are doing a double crown technique. So outside, outside crown, I would like to give use the observable tag. Then around the defect, you can use a suture, intracorporal suture material, which has a tensile strength twice more than the tag fixation, and also it is cost effective.
Okay. Okay. So right, so we will now go on to the next clinical. Yeah, Dr. Macky, you want to say something?
No, I'm good.
Sumeet, I want to say something, just interrupting you. You've got 8 minutes to go, so you might as well like to do 1 or 2 cases according to your, preference. Okay?
Yeah, right. So we will take one more clinical scenario with us, and which is of a little complex hernia now. And this is now a large complex ventral hernia. It may be associated with obesity and or it may be multiple recurrent hernias with previous ostomy sites and all that. And defect size is almost always 12 centimeter. Now, Dr. Faylona, is there any role of minimally invasive surgery in such situations? Do you think that?
No. I don't think there is a role for minimally invasive. The pictures that you're showing now, defect size of more than 15 centimeters. I would rather do this in the open technique because I have more control of what I can do. I have more options as to what I can do as well.
Right. So once you do an open repair, Dr. Bhatia, what is your choice of doing the component separation? Would you like to go with the anterior or the posterior, or you think that the component separation is not required and we can do without the component separation?
No, honestly, I feel that if this kind of situation is there, the message which I want to give to my younger colleagues is it is better to refer the patients to Sarfraz or Sumeet or anyone who is doing the component separation.
Or to you?
Yes, I will. And second, and second thing is that if, for example, if I am supposed to do an open surgery, I should analyze my limits, that whether I am good in doing the posterior component separation techniques or not. But in this situation, offer would be posterior component separation technique.
Right. Dr. Ganesh, what is your experience in, or your, anterior versus posterior? What do you think are the sort of, benefits and challenges of anterior or a posterior approach?
Yeah, definitely I would like to go ahead with an posterior component separation technique because the defect size is more than 15 centimeter. So
right.
if I prefer an anterior component separation technique, I don't think so that I'll be able to reconstruct the hernia alba in the midline. The main motto behind any component separation technique is a reconstruction of the hernia alba in the midline and to restore the integrity and function of the abdominal wall. So with the defect more than 15 centimeter, I don't think so that anterior component separation technique would suffice in bringing the hernia alba in the midline. At the more, we can get 4 centimeter to 5 centimeters each on either sides, but still there's a wide gap which will be left in the hernia alba. So definitely I'd like to go out with the posterior component separation.
Right. So Dr. Meenakshi, any other advantages like, if we do an anterior component separation, we'll put an onlay mesh. But if we do a posterior component separation, we'll put a sublay or a retromuscular mesh. So can you tell us something about the advantages of putting a retromuscular mesh?
So the majority of studies have proved that the best site for placement of a mesh is a sublate position. And also because the retromuscular space is well vascularized, we not only keep the patient the infection away from the mesh, but it also gets well integrated into the tissues. So that is one added advantage of the sublate position.
Right. And also now with, this PCST TAR technique, we can take the mesh right from one flank to the other flank and from the subdiaphragmatic area right up to the pubic bone, ensuring a complete, like a giant prosthetic reinforcement of the visceral sac. But taking up these patients is a huge challenge. And Dr. Goel, what kind of preparation would you like before you take up these patients for surgery?
Before you ask, I want to ask you, Parveen or Sarfraz, whether this type of hernia can be done with the TAR technique laparoscopically?
Sorry, I didn't get kind of.
TAR, he says that this kind of situations, can it be tackled by TAR, by laparoscopic method or no?
No, I think Dr. Faylona said there is no question of laparoscopy and there is open approach, and I think all of us agree. So if anybody wants a minimal accessibility approach, it's a different, but yeah, this has to be an open approach.
Sorry, I could not able to listen to you.
Yeah, I'm saying that
Hello?
I think we all agree that these situations are difficult to tackle by laparoscopy and an open approach may be better.
Okay, right. Thank you.
Right. So now preparing these patients for surgery, Dr. Bhatia, we know that it is not easy to take up these patients directly for operation. What would be your preparation ways to get them ready for the surgery?
I would say that, as Dr. Faylona had also mentioned, that I will always go in for CECT and C for the defect size and multiplicity of the defects. And then most important is that right from the beginning, we should encourage the patient to have good incentive spirometry. For example, that as these kind of situations are there, patients will have a compromise, can have the compromise in the immediate post-op period with the respiratory challenges. So one should always try and tell them that no smoking, decrease your weight, carry on doing incentive spirometry, and then definitely there are situations, not like this, but there are situations if the loss of domain is there or the hernia is too big, then maybe injections or PPP or Botros, and these kind of injections can be given. But again and again, our thinking is take care of the respiratory challenges, anticipate that.
Thank you, Dr. Bhatia. Sarfaraz, I think it is 4:35. I have other clinical scenarios, but I think it's difficult to take them because we have to stick to time. So I must thank my panelists, Dr. Parveen Bhatia, Dr. Macky Faylona, Dr. Meenakshi Sharma, Dr. Ganesh Shenoy. Thanks he could join us, and Dr. Amitabh Goel from Indore for joining me in this panel discussion. I hope that we have been able to get at least some messages across, starting from simple hernias, what to do, mesh is better, laparoscopy is better, closure of the facial defects is better. Different clinical situations will demand different approaches. As the hernia becomes larger, we need to work them up more. What is the type of mesh we can place, and the size and the fixation techniques? And of course, if they are large complex hernias, they are more challenging and require different set of approach and preparation and surgical techniques to repair them. Thank you so much, everybody. Over to Sarfaraz.
Thank you. Before Sarfraz says, I would say that Sumeet has done a great job. But even if he was not seeing our faces, but he could still go on and bombard us with the question. Thank you very much, Sumeet. Great job done.
Thank you so much. Thank you so much.
Thank you. Thank you. Thank you.